Now, to talk about our mission, last night you would have heard me say it's really threefold, and it's about providing reliable, trustworthy information, funding research, and advocating for people living with headache disease. And each night I'm going to be highlighting a different element that helps us move towards those goals. And so tonight we're talking about the medically reviewed articles. So we've recently added a whole bunch of new articles and content, and some of which have video attached as well from headache experts and specialists. So if you haven't visited the website in a while, if you've just registered for this event, but you haven't sort of explored some of the articles, it might be worth taking another look. Some of these articles have been recently updated in the last few months with current and the latest sort of best practice in thinking and research on the topic. So that's something that we're working on. We know it's sort of it's a job that's always, that there's always more to do. So we're working on that in a continual fashion to help improve that content for you. I'd like to also thank our sponsors for tonight: Hydrolite, Teva, Lilly, the Brain Foundation, Lundbeck, AbbVie, and Pfizer. They've helped make this event available and helped us reach many more people that we would have otherwise not reached as a result. So thank you warmly to our supporters. Now, who is this event for? If you have migraine or headache, if you're a parent, partner, or caregiver, if you'd like to connect with others like yourself, we have a support group on Facebook. I know that's not the most easiest social network, or may not be the preferred social network of choice, but the group function there has been there for a while, and we have a free group there. So for those that are using it, you're welcome to join. And also, if you would like to ask a question, you are in the right place. So before we start the presentation, I'd like to introduce Dr. Katherine Spira. She is a neurologist with a subspecialty interest in headache. She is certainly what you'd consider to be a headache specialist. She works at Spira Neurology, which is based in Sydney, New South Wales, in Randwick, for those that are located in Sydney. She collaborates with the University of New South Wales. She's an associate lecturer. She's also a passionate medical educator, so she teaches other doctors in neurology at the University of Sydney, and she also trains them at the Prince of Wales Hospital. So we're very fortunate to have Dr. Katherine Spira join us. And with that, we'll transition over to her presentation.
Hi, I'm Katherine Spira, and I want to thank Headache Australia and the Brain Foundation for asking me to speak today at this meeting. I'm going to be speaking about something I know all about, both as a doctor and as a person who's got a lot of migraine in my family, which is migraine and how it changes through the human life cycle. And with a real focus on safety and the things that you've asked that you want to know about today. So to tell you a little bit about myself, I am a doctor who specializes in migraine. I'm a neurologist. I work in a private practice that I run with my father, and he's also a migraine specialist. And I'm also what happens when a migraine specialist neurologist marries into a family of people who suffer from refractory chronic migraine. And you get me, I'm a migraine specialist, and I have multi-drug refractory chronic migraine, as does much of my family. So you can see my grandmother here, who blames herself for giving everyone else migraine, but who is, way down the line of many generations of migraine sufferers. And you can see a photo of my mum and my siblings from when my mum was my age. And I can tell you that myself and one of my other siblings has chronic migraine, and the others have high frequency episodic migraine. And my mother, unfortunately, also has chronic migraine. So I've seen everyone go through all these life stages in my own family. Although I'm not talking about that, I'm talking about the pattern for most people in research that we know on a population level. So I'm also a researcher, and these are some of my research collaborators. And it's a team of neurologists and optometrists. And we look at the endings of the trigeminal nerve that are visible at the surface of the human eye. And we can see the changes and remodeling that occurs in the nerve endings of patients with migraine, and what the changes are between acute and chronic migraine. And also we can measure many of the factors that are necessary for generating a migraine in human tears. So we are currently running a clinical trial where we're looking at add-on therapy in chronic migraine, which many of the patients watching this, I'm sure, would be eligible to participate in. it's a really harmless therapy, and it may be very helpful. And I'd love to see as many of you as possible involved in our research. I also want to invite you to let us look at your eyes, even if you're not a chronic migraine sufferer. We're looking at the eyes of all patients with migraine and trying to understand the factors that affect the nerve endings and also the chemical composition of tears in these patients. And we're hoping to really change the landscape of migraine treatment into the future and change our understanding of this fascinating and very debilitating common condition. So if you want to know more about our research or how you can get involved specifically, there's a research page on my practice website, and it has links to contact details and things like that that you might need to get involved. But I would really like to talk to you about what I've been asked to speak about. And this is a topic based on the questions that you've submitted. And it looks at the changes in this chronic disease over the lifespan. What is expected to change about your migraine? What's dangerous that could change about your migraine? What are the interactions between migraine and other health issues or other states during the human lifespan? And also, what medicines are safe and what's not safe, and what do you need to think about as you go through pregnancy, as you go through aging? The talk is arranged chronologically. We start with children and we end up with old people. Some of the talks about women, some's about men, and some about all genders. And this is signposted along the way. So starting out, this is a graph of the incidence of migraine in younger people. And the open circles are boys and men, and the shaded circles are women. And as you can see, at the age of 5, so in early childhood, migraine is more common in boys than girls. And in different surveys, there are different figures on where this crosses over and where it becomes more common in girls and women, but it's generally around puberty and the time of menstruation. So starting with childhood, migraine, I've got a picture here of my poor daughter who started UK at the beginning of the year and has recently, unfortunately, developed migraine. So I now know what it feels like to be the mum of a child with migraine and how stressful and sad that can be. So she's in that photo, but migraines in childhood tend to be briefer, and depending on the child's age and recognizing the migraine may be difficult. I know with my daughter, she just started having, she's a very happy girl who started having tantrums and complaining that everything was too bright and then feeling like she wanted to vomit. And that was really the beginning of this all starting off. And of course, she didn't understand what was going on. Medication can be very simple. Paracetamol is really useful if taken at the onset of migraine. Often the kids being at school is a problem, so you have to set up a plan with the school, maybe give permission for paracetamol to be given to your child when you're not there. Preventatives are usually not used, but lifestyle factors in children such as sleep and making sure they're eating regularly can be very helpful. And of course, in children and adults, stress and other factors in life can lead to this being, a more intractable or more treatable problem. So looking at the child as a whole. In adolescence, you have this interesting crossover where migraines can either behave like pediatric migraines or like adult migraines. And at this stage, especially as the child grows, it sometimes becomes necessary to consider other acute therapies such as triptans. As the child gets even older, often if it's treatment resistant or high frequency, it may become appropriate to consider preventative treatment. And unfortunately, this usually coincides with kids doing HSC, and exams and migraine treatment, of course, can interact in not so good ways when we've got treatments that can make kids quite drowsy. In adolescence as well, possibly more than at any other point in the lifespan, psychosocial factors and pain are very strongly linked. And when I see an adolescent with intractable migraine, I'm always thinking about them like I would about any patient as a whole person and trying to see if there are any factors in the background that may be contributing to the migraine. Of course, women start to menstruate in their adolescence as well. And for many women, this is the time that they experience their first migraine. It may or may not signal the beginning of a hormonal pattern of migraine. And for most menstruating women, as this continues on through life, the worst migraines tend to be in the days before or the first days of the menstrual period. Of course, there'll be people watching this lecture who don't have that pattern but have some other hormonal pattern. but that's certainly the most robustly well understood of all the patterns. And we believe that this trigger is actually a fall in blood estrogen level, which occurs around that time of the cycle. But as a rough rule of thumb, migraines in women tend to be most difficult to manage at times of hormonal fluctuation and transition. So that's adolescence, that's the sometimes the first trimester of pregnancy, cessation of lactation, and then perimenopause. It's also worth remembering the factors that are operating in the background of people's lives as they get older, because these are the things that are impacted by the disability associated with migraine. So little people problems are things like school attendance, exams, family dynamics and relationships. In adolescence, normal independent and experimental behaviors and forging an independent identity can be impacted by migraine. Also participation in sport, as this can sometimes exacerbate migraine, and the formation of peer friendships, and people having difficulty relating to their peers due to their disability. As people grow into big people, they get big people problems. So migraines affect studies, training, and employment. There is a clear relationship in South America anyway, where this has been studied in depth, between women with migraine and ending up in violent relationships and sort of abusive home situations. Physical fitness can be impacted, and social participation as well. This graph then zooms out a little bit on that early life picture and looks at the migraine incidence in women and men over the lifespan. And as you can see, there's a real peak around the middle of the reproductive years and a fall as people get older. And this is mirrored in both genders. So one thing that again happens to women, but not men by, well, people with uteruses and ovaries, but not otherwise, is pregnancy and lactation. So the most common pattern is that migraines improve with the progress of pregnancy. So for some people, they're a bit worse in the first trimester, but for most people, they're better throughout. And the further they go along, the less migraines they will experience. This is not true for all women. And I do meet about 6 women a year who have been sent to me in pregnancy specifically because their migraines are intractable and have come on for the first time. This effect continues until the cessation of lactation, when there's a bit of a rocky period again, and migraine patients have a slightly increased risk of medical complications of pregnancy, particularly preeclampsia, which can be well managed. I do feel that migraine patients are undertreated in general, but particularly during pregnancy, when many doctors are afraid to prescribe medications for pregnant women, even though they've been shown to be safe over a long period of time and in multiple sets of registry data. Triptans are very safe to take in pregnancy, and nausea medications are commonly used not just to manage the nausea of migraine, but to manage hyperemesis gravidarum, which is a recognized medical complication of pregnancy. So there's huge amounts of data on the outcomes of pregnancies affected by these drugs. Also, I think we've got reasonably good data on many of the preventative therapies, and these should be continued. And I back this so much that I have to say I took my preventative and triptans throughout both of my pregnancies, and I have 2 fabulous children. I know that's not very scientific, but it just shows that, you know, that's how far I back my confidence that these medicines are safe. I'd be willing to take them myself, and for that to affect my family. I think the bigger problem is that there's a perception that pregnant women don't need to do very much other than gestate, and so it's okay if their migraines go a bit out of control. But there's evidence that women with migraine limit the size of their families if they are not well during their pregnancies, and I think that's a real shame. There are lots of resources you can consult if you're considering a pregnancy and you have migraine and are on treatment. There's MotherSafe, which is our New South Wales-based medicines information service for patients and doctors in pregnancy. There are obstetric physicians who are used to treating women with medication during pregnancies. And there are, of course, people like me who are neurologists with special interests in managing women during pregnancy. Then you've got perimenopause, when hormone levels fluctuate wildly. Migraines can often become worse, more frequent, and aura can be a much bigger problem at this time. And there are a whole range of solutions to this issue. Sometimes hormone therapy helps, but more often it's actually treating the migraines with migraine medication. But many women who need a lot of medicine during the perimenopausal period actually get much better in established menopause, when migraines usually improve. I certainly, again, see lots of women who get migraine for the first time in menopause, but it's rare and far more likely that you'll grow out of this, just like all the other people in that graph at the beginning. There are also really interesting changes in migraine in men who age. From the late 50s onwards, many men lose the pain associated with their migraine, and also visual aura without migraine can become far more common, including in men who have never had migraine before. So this can be something that's happening fairly frequently, but not causing significant disability or pain, but causing a lot of distress when it first starts. So as we grow up more, we go from being a sort of young to middle-aged adult, having usually less other medical problems and maybe some mental health issues from the burden of untreated pain, which doesn't need to be untreated. And then we go into being a middle-aged to older adult, and suddenly things start getting a little bit more frantic with our health. We develop more vascular risk factors like blood pressure, diabetes, cholesterol. We may go on to develop heart disease and stroke. And of course, as we get older, there's also a risk of an increasing incidence of cognitive decline and neurodegenerative conditions. So patients often want to know, is it safe for me to continue my medicines as I get older? How do I know if this migraine that I'm having now with really severe aura is just another one of my migraines, or is it a stroke? And how do I know when I need to worry about my headaches generally? So let's talk first about medication safety. And I know that many of you have asked about triptan safety in aging, but I'd also like to talk a little bit about some preventatives that you might be taking that may require review, but equally may be completely fine to continue. So triptans are medications such as Zomig, Naramig, Imigran, Maxalt, and Relpax. Those are the ones that are available in Australia at the moment. And while we're talking about triptans, what I'm about to say also applies to ergots, which is the older family of drugs that the triptans largely replaced, but many involved migraine patients will be on compounded ergot preparations. They work in a similar way, and so these sort of safety messages really go for both of them. So how do triptans work? At the beginning of the pain phase of migraine, CGRP and vasodilators are released. This causes blood vessels in the brain to expand, and then those vessels stretch pain fibers and you get that sort of horrible throbbing pain. Triptans reduce the caliber of those blood vessels back to normal, but they can constrict them a little bit more than is normal as well. So this is very helpful when it's happening in the trigeminal cervical system because it aborts the migraine, but it can also cause constriction of other blood vessel beds. The picture I've got here on this slide is a picture of Raynaud's phenomenon, which can happen when blood vessels constrict in the extremities, such as fingers and toes, which can become pale, cold, or even blue. This can be a dangerous process, or it can be something that can be managed, but it's much more likely to start happening as you get older. And things that happen here can happen in other blood vessel beds. And the one that everyone worries about the most is the heart. So this is a picture of a beautiful open coronary angiogram. But of course, if you've got narrow blood vessels or focal narrowings of your blood vessels, and you narrow those vessels even more by using a triptan, sure, you can cause problems. But really, the majority of chest pain that's caused by triptans as a side effect has nothing to do with coronary artery constriction. What we found is that in severe coronary disease, triptans should not be used, but it really doesn't seem to be a problem in lesser degrees of disease. And really, what should you do about this? Well, if you know that you've got severe cardiac disease, you need permission from your cardiologist to use a triptan. Not every single time, but just generally some advice around that. But if you're just a regular person with a chronic disease like chronic migraine, like migraine of any kind, or even if you're just a regular person who gets the occasional migraine, your best insurance as you get older is to have a good GP with whom you have a good relationship and to engage in regular healthcare and screening so that you don't discover that you have a problem with your heart next time you take a triptan, but you sort of can mitigate that risk moving forward and not even end up with this problem. I just wanted to talk a little bit about tricyclic antidepressants because many migraine sufferers take these to prevent attacks. and they're wonderful drugs, and you shouldn't stop taking them for no reason. But it is worth considering the effects on this as you get older. So these are drugs like amitriptyline, nortriptyline, dothipam, imipramine, and clomipramine. Tricyclic antidepressants act broadly on a number of neurotransmitter systems in the brain, and as a result, in older patients, this can start to have effects as the brain ages and changes. It can affect memory, sleep, blood pressure, or continence, or interact with other medications, particularly medications that may affect, maybe they're to help you go to the toilet more easily and things like that. Also, you should think about medicines like Lyrica, Neurontin, and opioid painkillers, which can also affect cognition as you get older. But one thing that always affects cognition in older people is untreated pain. And usually having untreated pain is a much bigger problem than being on a medicine that may not be causing a problem. So I think if you start having problems associated with using this medication, or there's a possibility, you started taking it 20 years ago and you may have grown out of your headaches, I think trying a withdrawal of the medication makes sense. But I wouldn't withdraw the medication if there's no question that you absolutely need it to manage your pain and there's no indication that you're having any problem for it. So if it ain't broke, don't fix it. Stay on the medicine. But once again, having good relationships with your primary care physicians means you can go back and ask them whether you should keep taking the medicine or not, whether you need to consider alternatives, and they'll know you and they'll be able to guide you along that process. One thing that I sometimes get asked about in my practice is, I get migraine aura and I'm getting older. How do I know when I'm having a stroke? What if it's just a migraine aura? And I've certainly seen patients get it wrong in both directions, but I tend not to mind too much if they got it right, if they got it wrong in an overly cautious direction. I think that's just safe. So the question of, is it a stroke or a migraine? I think if your aura is much longer than usual, so say that you have an aura that lasts 20 minutes and you've got an aura for 1 hour or more, I think that probably warrants a trip to emergency. I think if you have something that seems markedly out of keeping with your previous pattern of aura or migraine, it is worth going to emergency. And I think if you've grown out of your headaches and suddenly you're getting headache and a balance or coordination problem, or just something that's never happened before, just go, because stroke treatment now is so excellent. That's something that's changed since I was an intern, that we have, so many wonderful treatments for acute stroke. People come in, can't talk, can't move half their body, and they walk out the next day and never happens again. I think much better to go and get checked out. If you think you might be having a stroke, just call the ambulance and go to emergency. And in general, I thought, well, this isn't just something that people who get older worry about. This is actually something that a lot of migraine patients worry about throughout their life. So when do you need to worry? When do you need to seek review, either urgently or from your GP or neurologist? So one thing that should always go to the emergency department is the sudden onset worst headache of your life. So where in less than a minute, you go from being a normal person to having an absolutely severe headache. I think that's important. If you have a change in the normal pattern of your headaches, especially going from having intermittent migraines to having a headache every day, you definitely need to see your doctor. If you grew out of your headaches, say around your 50s, and then they suddenly come back much worse in your 70s, maybe with other symptoms, you need to go and see a doctor. As mentioned, if you have a very prolonged visual aura or any other kind of sensory or motor aura, you do need to go to the hospital. If you're getting new neurological problems with your headaches, same thing there. You should also go and see your doctor if you get anything systemic with your headaches, such as fever, weight loss, or persistent vomiting. So overall, the take-home messages of my talk is, firstly, don't forget that migraine can be treated well in the vast majority of patients through all stages of life. Go and get treated. Go get seen by a doctor and see what you can do to push the envelope on your migraine care. It will change through your life, and we're getting new treatments now all the time. It's a great time to be in migraine medicine. Migraine is a chronic illness, and so some changes to your symptoms are normal in different stages of life, but your migraine story is unique. And what I've told you today may or may not apply in its entirety to you as a person or to members of your family. the last take-home message is probably the most important, and that's that you should be looking after yourself. You should have a good relationship with a GP you trust and keep up to date with regular health screening checks. If you have a neurologist or need one, you should be seeing them until your treatment is stabilized and you're well. And just like every other person, you can have emergencies and you should respond to them like any other person would. Thank you so much for asking me to speak today. It's been a real pleasure. I'm very happy to answer your questions at the end of the session.
We're going to transition now to questions. We've got Dr. Spira with us for those questions. Thank you for that wonderful presentation. It was great to see some things that I knew, but also quite a few things that I'd learned. So I hope everyone found it valuable, and we certainly have no shortage of questions. So we'll dive right in, and fortunately, we've got still another half an hour, so we can go through and get through many of these questions. And if you haven't sent in your question yet, please do. We'll be monitoring those as well. So first question was from Ali, who asked about how common it is to have sudden onset of continuous migraine from the age of 40 and what might have been a trigger for that.
So it's not particularly common, but I do see it in my practice all the time, unfortunately. I've had it start for absolutely no reason. I've had people start from having trivial head impact. I've got one patient who a plastic child's chair fell on her head, barely causing any problem, and she's been in pain ever since. So it's very variable. Unfortunately, this does happen. There is also a phenomenon, though, called new daily persistent headache, which is a headache of clearly remembered onset, which is continuous from the time that it starts. Occasionally, there's a short period of remission at some stage in that headache and it comes back. It can also just spontaneously remit. So I would be wondering whether it is migraine or new daily persistent headache. A lot of new daily persistent headache is very bland and doesn't have features of migraine such as light and sound sensitivity, nausea and vomiting, but some people do have prominent migrainous features in their new daily persistent headache. So it will be one of those two headaches. The treatment is similar in both cases, though. The options are similar.
And for those that are interested in new daily persistent headache, we have headache types featuring tomorrow at 11 a.m. With Dr. Jason Ray, so you'll be able to learn more about those types. The next question is from Graham. He said that my migraine attack started when I was 60 and became more frequent as I got older. I've tried every medication, including Botox, but the only thing that seems to work are triptans. What's he missing?
So, look, you may have tried everything. It's a lot of medicines to try everything. You've got to try, I think there are about 18 standard tablets. There are a few I try if those aren't working. And then you've got the new CGRP medications as well as Botox. And there are also some new nerve stimulator devices and other options as well that are non-pharmacological. You may not be missing anything, though. Unfortunately, I do have some patients that get to what I consider to be the end of my line in terms of treatments that I'm familiar with. I do, at that stage, trial other things that are a bit different. So sometimes CBD or THC CBD combination products, and also looking at other factors that may be contributing to the migraine. And also, if you're living with a large amount of continuous pain, it usually causes depression and anxiety as well. So managing those things, even if you remain in terrible chronic pain, and working on mindfulness type approaches can really help you to have a better quality of life, even if your pain has failed all potential therapies. So I've got other approaches I use if I've gotten to the end of all my medicines, but unfortunately, now that I think my practice has been going for 6 years or more now, so I certainly have patients who I've taken through all of those medications who have failed. It's a very difficult and dispiriting situation to be in, especially, I would imagine, towards the end of life. not the end of life. Sorry, 60. It's a terrible thing to say. But I mean more. When you've got a lot of things, going on and pots on the boil in life, and you're in chronic pain, it's terrible and it's exhausting. But I think there's a point where you sort of want to sit back and enjoy yourself a little bit. And I think certainly having that kind of intractable, terrible pain and symptoms going on in older age is very difficult, and usually causes a significant amount of depression. So my tips would be, I guess, if you really have failed everything, to manage all the factors in your life that are modifiable, to try and improve your quality of life as much as possible, but also to make sure that you've actually gone through and you have tried everything, because maybe there's something you haven't tried.
Yeah. I mean, with the medications, sometimes those medications, the preventives, can be combined. Certainly the acute medications can be combined, and there's sort of adjustments that can be made to dosing as well. Then there's devices, and there's more devices coming out. But then there's other areas like therapies and alternative treatments and complementary treatments that can also go alongside, and lifestyle and behavioral interventions. And you mentioned your mental health, anxiety, depression. I saw a presentation from a headache specialist in the US that spoke about how it's very common to have anxiety and depression when you have an illness that no one understands, that strikes at unpredictable times, that you don't have control over, and that has a certain level of stigma over. So even though there's a stigma associated with depression to some extent, it's a perfectly normal response to being what is essentially in a state of frequent torture, right? That very few people understand. So I don't think we should feel any additional shame or guilt as a result of that. And if we're able to improve anxiety or depression, often that improves the migraine itself, ironically, even if that's all you change regarding your health. So there are plenty of options there, I think.
There was one other aspect to that question, actually, Carl, and that is the issue of using triptans very frequently, which I think we should sorry, I just was thinking of it while you were speaking, but I totally agree. I mean, the stigma surrounding migraine is huge, and I think a lot of women just get dismissed, but a lot of men get labelled in very unflattering terms if they have chronic pain. It's very difficult to live with in so many ways. So the issue is about triptan use. So there is a phenomenon called medication overuse headache, and it's often a very important thing to address. It's amazing how the drug that we feel we depend on to be able to function in daily life, the only thing that gives us relief, can end up being a case of too much of a good thing. It's not a good thing anymore. So if you are using triptan medications in excess of 10 days per month on a regular basis, same with codeine or compound analgesics, you actually are in a situation where you could be potentiating an increased frequency and increased severity of migraine attacks, and getting into a situation where the medications you're using don't work as reliably as possible. And often the point where the medicines become unreliable is the point where the patient comes to seek help with their headaches. It's a really common point where people decide to come and see me, who have been suffering for a long time. Often addressing the medication overuse and getting people off their triptans or codeine or whatever it is for a period of 2 weeks can make a massive difference in reducing the frequency of their headaches. Now, equally, I've got lots of patients I've done that for, and they still have chronic migraine, but often they actually do have a significant reduction in severity, and then the preventative medicines that we're introducing work better. So addressing that kind of terrible, intractable headache is quite complex, and especially in the setting of medication overuse. So it's an important thing to kind of get your head around as well. And it's difficult to accept. I think I've certainly been in that situation myself as a younger person, and even until I did my physician's exams, I couldn't think of not using an ergot or triptan every day, because how else was I supposed to get out of bed and go to work? So I understand the anxiety about thinking about changing or stopping something that you're using like that. I think it's very powerful. But and you only end up in that situation because you're so sick to start with, and the preventatives aren't working. It's not like you're, drug seeking, or it's particularly fun to take Immigrant. I mean, I don't know anyone that gets a thrill out of that. So it's kind of a horrible label to have put on yourself that you're overusing medication. But if you understand what it means, which is a non-pejorative thing, and it's just about a pattern of use, then we can address it and really produce really significant improvements in quality of life and pain levels for people as well.
Peter Hall noticed the graph showing how migraine declines typically as you age, and a lot of people have been promised by their doctors that after menopause, things get a lot better for the majority of people. And the graph tells us that in a population, that's true, but people that are watching tonight are obviously still struggling with migraine or want to learn more about migraine, and have been felt like they've been lied to, like the promise has been broken. How do you manage individuals like that?
It's really hard, and there are also many people that they start having migraine in older age, or at the time. I've got loads of women that have gotten menopause gotten migraine, chronic migraine for the first time in established menopause, and men as well who started getting auras and then progressed to having chronic migraine. It's very it's on a population level, yes, exactly as you said, Carl, very unusual, but on an individual level, anything can happen. I manage people in that situation the same way that I manage younger people, with the same medications, except I might choose a different order of medications to try first, second, third, and whatever. Because I really want to focus on giving older people medicines that are less likely to be dangerous as they age and accumulate other problems. It is such a sad thing when you've been holding out for something and then it arrives and it's not quite what you expected, or it's worse. And it does happen to some people. I know certainly given what's happened to my grandma and my mum, I'm not expecting my migraines to go away with menopause at all. But I try and sort of temper the way I explain it to patients is this is likely to happen, but I can't guarantee that it will happen. But let's hope, because everyone needs a bit of hope.
So we spoke about menopause. There's a couple of questions related to hormones here. One's from Helene, who asked if there's been any treatment or action that's been found to help reduce the intensity of migraine around and during menstrual periods.
So we can treat pure menstrual related migraine in a very specific way, but what I've found to be what most people end up on is the standard preventative that they take all month long. So most menstruating women who get migraines both during their menstrual periods and also at other times of the month. And those people need to just be managed in a very standard way. The people there are a very small subset of women who only get migraine during menstruation, and they can be managed if they have regular periods by predicting when they're going to get the period, and by starting to take a long-acting triptan drug daily to twice a day at the beginning of the 1 to 2 days before the menstrual period and for the first 3 days of the menstrual period. So almost using a triptan like a preventative drug. It's not for all patients, but for those patients that can be helpful. And I do also have patients who have had chronic migraine, I treat the chronic migraine and they end up in that pattern. And then I use the triptans in that way. The problem is at the end of that, you end up with patients having a withdrawal headache from the triptan, but it's usually less severe than the migraines that they would have had during their period otherwise. So that's a specific way that we manage pure menstrual migraine. Otherwise, we manage it in the same way that we manage high-frequency episodic migraine or chronic migraine, exactly the same way.
Angela has PCOS, and she says she gets a migraine when she ovulates and then another when menstruation starts. She said that you mentioned low estrogen, but does the increase in testosterone cause migraine?
So these are great questions. I think there are many women who do, like from my clinical experience, who do have progesterone-related and testosterone-related migraine patterns, but the state of research is very much the things that have most consistently shown as patterns across the population have been the more common pattern of estrogen only related. So I can't comment on that. I certainly have patients that have been put on progesterone-only pills who have gone on to have no migraine and come back very annoyed with me that I didn't suggest that up front. It's just that we don't have great amounts of research on those patterns, but I do believe that in some women they exist for sure, and sometimes there can be unusual solutions to those situations. If it's a very clear pattern, I do have certain gynecologists that I refer to advise on different hormone treatment options.
There's a few people, one of whom is Ali, who's interested in the correlation between birth control and migraine. Can you talk about that?
Yeah, sure. So there are a few things to say around this area. First of all, women who get migraine with visual aura are at, and I don't want to say this in a way that panics anyone because it's a tiny, minute increase in risk, but there is a very small increase in the risk of baseline stroke in women like this. Now, for women on the combined oral contraceptive pill, so estrogen containing and progesterone containing, the estrogen element also adds a very tiny increase to the risk of stroke. Now, I doubt anyone who's taken the oral contraceptive pill in the audience has ever been warned about this because it's a tiny risk. And in a similar way, I don't think it's worth every woman who's ever had migraine with visual aura walking around worrying if she's going to have a stroke either. The key is that when you add, if you have migraine with visual aura and you take the combined oral contraceptive pill, you do have a very tiny increased risk in having a stroke, and you've just added two very tiny risks to make another very tiny risk, because the odds of having a stroke in reproductive age outside of pregnancy are very, very small. So that's sort of safety disclosure to get out of the way at the beginning of answering that. Then you've got the interaction between migraine and the combined oral contraceptive pill. Many women get their first migraine when they go onto the pill, or their first visual aura when they go onto the pill. And I think if that happens with aura, you should probably look at other options for birth control. If you have other reasons for being on estrogen, the benefits of that may outweigh the risks of what you're doing. And I certainly have many women who are really dependent on HRT, many women who are really dependent on the oral contraceptive pill to control other health issues. And I think in those settings, by all means, go right ahead. But yeah, for some women, certainly being on high dose estrogen or progesterone can exacerbate their migraines, just as there are women who will go on progesterone and their migraines will improve. It's a very individual thing, and I think as long as you're aware of it, that's the important part. Certainly, I have also seen women who have started getting migraines when they get or their migraines get worse around getting a Mirena put in. Any kind of hormonal contraception can affect your headaches. But if I had to make a general statement, I think the best methods of birth control for women with migraines are those that mainly use progesterone or barrier methods and achieve the lowest possible blood dose of hormones. So the Mirena is actually one of my favorites for that reason. But if you don't get visual aura, you really can safely take any hormonal contraceptive option.
Great. Thank you for that. And I'm just going to share on the slides here a bit of a summary that's been put together of what was covered, just in case you had some questions that might be addressed here. But we'll keep going with the questions as well whilst we have this up. The next question was regarding adolescence, and we have Dia, who has a daughter of 14, has had migraines since she was 4, and she's now having 3 migraine attacks a month. They don't want to use preventive medication at this stage, but they really want to address what is the underlying cause of her migraine condition. Would you suggest allergy testing? What else might you recommend?
Sure. I think this is a really difficult question in terms of how it plays out in real life, because I'm of the belief, with good scientific reasons, that Sure. I think if you're getting a couple of migraines a year, or maybe even one every couple of months, and you realize that you only ever get a migraine when you eat chocolate, by all means, trigger avoidance is, God to you. Just stop eating chocolate, stop having a massive bender and then not drinking enough water the next day. That's a perfectly achievable situation. But you also get situations at all ages where I get someone who walks into my office who hasn't had any alcohol in 15 years, is on a bizarre diet which barely has enough nutrition to feed them because they're avoiding a bunch of potential allergens and triggers, and has a rigid sleep routine that they don't have a social life because they can't deviate from it. So there's a whole, there's everything from having a completely wild lifestyle and wearing the migraine to having a really extremely restrictive lifestyle. I think with adolescents, lifestyle is absolutely key, but I also think at every age you need to really carefully weigh up how useful it's going to be to pursue trigger avoidance as a strategy. It sounds like your poor child has, had migraine from a very young age, and it sounds like a very established pattern. And I think in that kind of situation, you need to accept that even if you avoid many triggers and you go through the dietary process, you may find something very helpful, but equally you may end up with a restricted lifestyle but limited benefit, because this disease is not messing around. It's a terrible disease, as you can see, and we need to make sure, I guess, that migraine sufferers can face what life throws at them without being disabled by life. And the other thing that happens around adolescence that can be difficult to manage is normal human development, where you get, a child who's relating to you in a specific way and who's doing what you tell them to do, and someone that's pushing boundaries and doesn't want to avoid going out, has an independent life, can eat and drink things when you're not there, and managing and balancing that transition can be very difficult as well. So I think by all means, I personally think the most high yield things to address with adolescents is sleep. Sleep is so key. Most adolescents don't sleep enough that I see in practice. I've got an athlete who is getting up at 4:30 to train and goes to bed at 9:30 every night, and that's just not that's not enough sleep for a young person that's doing an extreme amount of physical exercise. So sleep's very key. With diet, I actually find the most useful thing is to even out variations in blood sugar by making sure that kids are eating regular nutritious meals. As basic as that sounds, particularly around adolescence, this can be a thing that goes totally haywire. As you know, kids get in fads. They don't like to sit down and eat what everyone else is eating, or there are all these weird things that happen. They start socializing and skipping meals, spending too much time on social media and forgetting to eat and drink for long periods of time. So if you can manage those very basic things, it usually helps. But if you've tried all of that, by all means, go into looking at other things, other lifestyle triggers, and avoiding them. I have had a bit of experience with kids avoiding allergens and ending up triggering their migraines through exposure treatment, particularly with people with sinus disease. Sometimes agitating and aggravating those things can cause a temporary worsening in headache. So I guess trigger avoidance is okay. Be careful that it's manageable and that it doesn't undermine your relationship or important things that the kids need to be doing. And addressing very basic things like sleep and food in a very sort of non-complicated way are usually the most important things in prevention. Yeah.
I mean, that sort of frequency of migraine per month, that's sort of around the 4 days a month, it's kind of like a threshold. Like it's like it could get a lot better or it could get worse. It's not likely to stay the same. I think what will determine that will be how it's managed and how that individual, like when you're 14, I think you could, the 14-year-old starts to, like, in my opinion, kind of really needs to know what's going on, like why migraines, how migraines work, like understanding some of the fundamentals, like even potentially, watching something like this, with the parents present, of course. And, if it was my child, I think as well, we know that children respond really well to things like cognitive behavioral therapy and like resilience, like stress, stress management resilience. And these are skills that you can give your child that not just great for migraine, but are great for, a whole variety of things, and great skills to have as well. And that can, that might be something that helps turn the corner as well. So I think there are a lot more options beyond just, medication. So hopefully that helps. So I'm conscious of the time. We've got 7 minutes left. I want to cover off migraine with old age. There's a couple of questions around dementia and cognitive issues. And there's also a couple of questions about aura as well. And so we might jump to these. So we had Helene, Sharon, and Charlotte all talk about aura, and mostly what they're saying is that they've had long auras. What does, for an aura that lasts a day or for hours, one of them was related to COVID, but what does it mean if you have an aura that lasts like, longer than just a few hours, like for a day or more?
That is really tricky. I think there's a difference between an aura that's continuous over a day and an aura that's coming and going. I also think there are patients who get very prolonged auras, and those patients probably don't need to worry as much if they have a very prolonged aura. But in general, if you have an aura that's way out of line and going much longer than your usual, I think that presenting to emergency is reasonable. The other thing is what you mean when you say aura. So there are a lot of visual phenomena that occur during migraines that are not visual aura. So things like visual blurring, a general sense of disequilibrium. Those sorts of things are not necessarily aura. I think if you're having classic visual aura where part of the visual field is obscured by positive visual phenomena such as colors, zigzag lines, etc., that is different. That is clearly a visual aura. So sometimes people use the word aura in different ways, but when I'm talking about visual aura, I mean that you've actually lost part of your vision, or there is a prolonged thing that you can see that isn't really there.
Thank you. One more question before we jump to the dementia and cognitive effects. There's been some studies that have linked early abuse in an early age or traumatic events, whether that's physical, emotional, or sexual. Can you talk about the connection between that and migraine?
I can. I mean, it's curious. I sometimes lose faith in humanity because so many of my patients tell me the most sad and terrible things have happened to them in their lives. I think a lot of this is actually around head injury from domestic abuse, which clearly, is given that any head trauma is very clearly linked to migraine. There are also, I think that there probably is a significant link between childhood abuse of different kinds, including sexual abuse and migraine. But I also believe that these things are actually much more common in our society than we really acknowledge generally. And probably if you have a chronic disease and a physician that you trust, you'll end up disclosing things like that. Whereas, you may not necessarily do that if you have a more acute condition. You're not going to confess to the orthopedic surgeon who fixed your broken arm that you've had problems, but someone on an ongoing basis, you might talk about that a bit more. So I know that, there have been studies looking at women with migraine being more implicated in domestic violence situations. There certainly is a known link between the development of chronic pain disorders generally and abuse in childhood. But yeah, I know from my practice it's very common, but I don't have more to say about it than that.
So when you have someone that's clearly still suffering from that trauma, is the solution to sort of see a psychiatrist, not to brush them off, but to work through those issues and try and find some sort of resolution?
Yeah, I do think having unresolved emotional issues and dealing with pain is a terrible recipe that causes, and it's greater than the sum of its parts in terms of the amount of suffering that the patient will go through. I do think that it is essential to managing migraine generally to always address any psychiatric problems that go along with the migraine, whether they are related or unrelated to the pain itself.
Okay. A couple of quick questions about the brain as we get older. So Angie wanted to know whether people who've suffered migraine most of their life, are they more likely or more at risk of dementia?
Good question. Probably not, although we are now looking at there does appear to be certain brain remodeling occurring in patients with poorly managed chronic migraine through life. And there's a Spanish neurologist that's particularly involved in looking at this at the moment. I was very saddened to find this out. It doesn't appear to be a dementia linkage per se. It actually looks like it's potentially due to chronic pain and neurophysiological changes that are occurring to do with central pain pathways more than dementia. And certainly there are lots of phenomena that we see in migraine sufferers that if we saw them in someone that didn't suffer migraine, would be a concern. So white matter lesions on an MRI in someone with chronic migraine, we know they're non-progressive and they're not associated with dementia. Whereas if you saw lots of them in someone without migraine, you think, oh, that's a bit strange. I wonder why they've got that. And they are much more likely to be progressive and associated with dementia. So yeah, you don't need to worry that you're going to become demented if you have bad migraines. It's more just there are other brain changes that may occur that we're just learning about now that are non-dementia related.
And lastly, Simone and Peter both sort of talked about the long-term effects of experiencing migraine and having difficulties remembering things or struggling to understand or hearing. How do you determine like if that's due to migraine or if it's just a natural part of aging and that's happening to a lot of people who are getting older?
So stuff I see people with and without migraine coming in every day about when they're worried about memory problems are forgetting names of places or names of people. That's really common. Just needing to write more things down. That's also pretty normal. I think we start thinking dementia when we're looking at people not showing up to appointments, thinking, forgetting important dates, when they're the person in the family that remembers everyone's birthday, starting to have trouble functioning in daily life. So it's difficult to tell. And I think certainly if you're groggy from medication or pain, migraine causes a significant amount of reversible cognitive impairment potentially for people during attacks. So it's usually aging. If you're worried about it, you can see your doctor. You can get a fairly quick screening test at your GP where they just go through some questions with you, and then you can go back in 6 months' time, see if you're the same or worse, and you can do that a few times just to reassure yourself if you're not sure. But the main thing is starting to lose the ability to cope with your daily life in different ways, more than just forgetting the occasional person's name that you haven't seen in a while.
And so I guess the takeaway message there is that there's no research that establishes a connection between migraine and cognitive decline or dementia. But there is research that's looking at the impact of chronic pain and how that affects the brain and therefore cognition and cognitive function, I guess, as you age.
Yeah, people, if you treat someone's depression or someone's chronic pain when they're old, their cognition will always improve. So, identifying that and treating it correctly can actually bring about massive improvements. And that's one of the most common things I do is put old people on antidepressants and watch them suddenly not be depressed, not be demented anymore. It's a really insidious hidden problem, and it's definitely associated with headache and chronic pain.
So it's never too late. Well, that's good. I think that's a great message to end on. Thank you so much, Dr. Katherine Spira, for your time and your expertise. It was a wonderful presentation and a very detailed Q&A. Thank you to the audience for attending. Tomorrow we have 2 webinars running, one at 11 a.m. in the morning and one at our usual time at 7:30. The morning session is on headache types, where we will be covering new daily persistent headache, cluster, and a number of other headache types. And we're going to be going through some Australian research this year as well in the evening session at 7:30, which will be another fantastic session. But for now, thank you very much. Good night, and we'll hopefully see you all tomorrow.